to see if I can share this to Twitter while I'm going live, because I think that it does go live, but I want to see. Yeah, that looks like it worked. So, thank you for joining me tonight. Happy New Year. It's good to see everybody. And I'm really excited to share this with you. To put it in the most brief words that I can put it in, we now have proof. We now have proof as to, well, what I have here that I'm going to share with everybody, and that Lauren and I have shared off of CIAG and our website with our member email tonight, is the proof that the guidelines just didn't come out of nowhere. The CDC just didn't have a rogue moment and write them for the sake of just writing them. This was mandated, it came down, and not only were the guidelines composed, but, oh, thank you. The same to you. Thank you. Thank you for joining me. Not only did the CDC make these guidelines, but it didn't come out of anywhere by itself. There was a lot of work in the background that occurred that led to this. And we found it. We found it, you guys. We found it. This is a big day. Okay, now we have the tools we need to stand up to the people that make the laws and say, we need to start talking about the truth. This was never about addiction. It was never just about the opioids. It was about redesigning healthcare. It was about changing the way that medicine was practiced. And it was changing the way how pain patients would be dealt with, because they meaning policymakers, government officials, researchers, they wanted to examine chronic pain. And the reason that they wanted to do this was so that they could study us in an effort to create strategies to implement toward certain populations of individuals so that they didn't end up with chronic pain and disabled. And also to, quote, for lack of a better word, rehabilitate those of us that are disabled. I'm going to tell you guys right now, I love your comments. Please post them. But I'm going to keep my eyes right up here, because if I lose my train of thought, I'm going to blow this, because this is going to be something I need to really focus on. But please, please leave the comments, because I go back and read them and they might start really good conversation amongst yourselves. Okay, so we know that Section 4305 of the Affordable Care Act was adopted into law. And a part of this, and I'm just going to, do my typical disclaimer. This is to the best of my ability, to the best of my knowledge. And I'm going to post the document that this came from so y'all can check it out for yourselves. We know that at that time, there were a lot of changes that were going on. And one of the things that they wanted to do is they wanted to study pain. And the reason for this is that the number one reason people go to seek out care, go to the ER, utilize their health care is because they have pain. And for many of us that have chronic illness, that pain cannot be cured. And so, to make a long story short, what the goal was to change how it was approached. In this report, which came from the NIH, that was disseminated at the end of September in 2014 and given to all the individuals working in the CDC and everywhere else before the guidelines were posted, they handed this off to this group. And what's interesting is in this group, we have a few notable people that were involved. We have Dr. Erin Krebs. Now, if you recall, she's the researcher and physician that, did that study where she's, claiming that Motrin and Tylenol are superior to opioids for pain. And as you look at the study, you can see that there was a lot of, you know, interesting little things that would make it not apply to the rest of us. I believe that they only looked at people that had a specific type of condition. I believe it was hips and knees or something to that effect. But from that study, it was twisted and turned into, well, Motrin and Tylenol are better. And this is the study that's being propped up there to base a lot of all this. Oh, well, opioids don't work as well. Now, I did have somebody approach me online and say the problem wasn't with the study, the problem was with it was interpreted. But I have to tell you guys, if I was a researcher and I saw my work being misinterpreted, I would get in there and make sure that it was done properly. So we have her. We also have Jane Ballantyne. We have Dr. David Taubin, who I saw with my own eyes at a conference, state that the goal of the place where he worked was to get all of the opioid chronic pain patients onto buprenorphine. We have Dr. David Clow, CLAUW, a professor of anesthesiology and medicine and psychiatry out in Michigan. And I saw a YouTube video where he was claiming he's not treated a patient with opioids in the past 10 years. Very active in the Michigan Open stuff. We have Dr. Robert Chow, who is from the Pacific Northwest Evidence-Based Practice Center. We've got, that's who we've got. And they are all with PROP, okay? So they all get together and they have this meeting and they write this report. And this report in the email that Lauren and I sent out tonight is there. So the interesting thing that starts out that you start to realize when you're reading this is they start out like typically these stories do, where they're talking about the fact that, chronic pain, estimated 100 million or 1/3 of the US population has this condition. And approximately 25 million people experience it to a moderate to severe enough level that it really significantly affects us and prevents us from being able to, work and have a good quality of life and things like that. And so what this work group acknowledged was that 5 to 8 million Americans are using opioids for long-term management of chronic pain. However, at the same time that they state that the increase in the prevalence of chronic pain is increasing, that the utilization of opioids is also increasing. And they say in this report that they recognize that we get pain relief, that opioids do work. However, what their concern appears to be is that while we're getting some relief, it's not improving our level of function. It's not getting us back to work. And so what they wanted to do is to see if they could explore other ways to integrate what they wanted to look at into our medical system. Okay. And I will explain that. So just bear with me here. So I wanted to say that the Pacific Northwest Evidence-Based Practice Center, under a contract with the AHRQ, which is the Agency for Healthcare Research and Quality. Now, in the past year, we've noticed in our community that they've been quite involved with the 6 building blocks and the CDC guidelines. So those were the people that took part in creating this report that I'm going to make sure that all of you have access to. Okay. They talk about societal costs being high. They talk about the psychological distress and social disruptions, high medical expenses that we as chronic pain patients generate and are faced with. Not anything but that. They do mention that part of the adverse outcomes is addiction, overdose, and insufficient pain relief. And that was their thing. That was they kind of honed in on, was the fact that while we say that our pain is relieved, that it's not relieved to the point where our function levels are increasing. So that was a big concern for them. Okay. They said that they recognized, and this was written back at the end of 2014, that patients were being, providers were quick to label us as drug seeking or quote addicts, and who overestimated our pain, and that some doctors fire patients for increasing their dose or merely continuing to voice concerns about their pain management, that we have negative interactions with our pharmacists, that we're viewed as criminals or feel as if we're viewed as criminals, and that we have feared that our pain relief medication is going to be taken away. So think about it, you guys. All the way back in 2014, before they implemented the guidelines, they were aware that these were the types of problems that we faced. Okay. They continue on to state, page 5, many patients have been compliant with their prescriptions, and some feel that their pain is managed adequately to the point of a satisfactory quality of life. However, many patients using opioids long term continue to have moderate to severe pain and diminished quality of life. So they're saying that we continue to have diminished quality of life, but there have plenty of people who are saying that our pain is relieved. We have a good quality of life, or an improved quality of life. We can get by, right? And I'm not saying everybody, but the general consensus. They say that while we experience substantial pain relief from the prescription, and that we do not suffer adverse side effects, that the benefits that we're receiving have to be weighed against what's best for the population. So here we go with the population health stuff. Okay. Now I want to tell you, in this report, it is very clear, very obvious that we are being studied. And that was the goal, was to study us, because they knew if they could study our population, what they could do. Like, we'll take myself, for example. She has dermatomyositis. If they study enough dermatomyositis patients, then maybe they would find out that, CBT and, I don't know, yoga work great. And so the goal was, when they study populations, and if they see other individuals coming up, the pipeline, for lack of a better word, that have similar symptoms to myself, or do have the early onset or diagnosis, not early onset, but the diagnosis of dermatomyositis, that they can use these strategies, implement them to prevent these individuals from becoming disabled. Now, I want to say again, I am not, and I'm going to speak for Lauren, okay, because her and I have spoken with this, and I want to make a statement in regards to CIAG. We are not against multimodal care. We are not against alternative or complementary therapies. What we're concerned about in this arena is your right to make a choice of what's best for you, to have a right to access. This is a civil rights issue now, you guys. This has gone way beyond opioids and just the CDC and getting our information and what Kolodny's doing any day of the week. This is a civil rights issue. Okay? They recognize here in the report that a very small percentage of us may end up struggling with addiction, but it is a small percent. So here we have, in their own words, at the NIH, stating they're benefiting, it works, they're not becoming addicted. But still, they still proceeded to go on and do it. Why? The answers are here. Okay? They also recognized that they had studies that went longer for 12 weeks. Remember, that was one of the things in the CDC guidelines when they were saying, we have no evidence, we have no evidence. They did. Okay? This is a very dense document. There's a lot in here. I'm going to cut through a lot. I want to get to the crux of the issue, which is the fact that they were not honest. I want you guys to think about all the times and all the people that went to our lawmakers and said, we're being harmed. The CDC guidelines are detrimental to our care and our well-being. And how many times and how many opportunities they had to tell us the truth. But see, they feel, or I'm guessing, I can't say how they feel, I can't speak to that, but my assumption is that Perhaps they didn't feel society could handle what they wanted to do, and that was study pain. I said it in one of my videos recently that if the government came forward and said, "Oh, we want to study pain," that people would have been like, "Huh? What?" But the moment they could attach the overdose crisis to it, that gave it a whole new life of its own. And all of a sudden, billions of dollars have been put forth to this. They had to leverage that crisis. Okay, that was evident in the national pain strategy when they said that, there were two different crises going on, one of untreated pain and one of addiction. Because part of what they say in here is that we have an over treatment of pain in some cases and an under treatment of pain. And in a lot of cases, that people were taking their pain medicine and just going about their life and not engaging in the multimodal alternative strategies because they knew that it worked. So they wanted to examine a more holistic approach to the management of chronic pain. They recognize right here that limiting or denying access to opioids for these patients can be harmful, yet they allowed it to happen. They said that data is lacking on the accuracy and effectiveness of risk prediction instruments. What is that? That's APRIS. That's the algorithms that are being put in our computers. But see, there was a reason they did that, and they get into that later in this document. They have, I believe it's 9 recommendations at the end of this report. And one of the recommendations was to enhance the PDMP and the connection between the PDMP and the electronic medical record, because that's how they would grab the data. They wanted the data. They knew that doctor shopping wasn't happening. But no, they knew that doctor shopping was not happening on a level that required billions of dollars to be thrown at it, okay? They knew the percentage rate was low. But see, they said that they implied that that's why we needed it, but that wasn't it. They wanted the data. And that's in this report so they could study pain. Do you guys go to the pain doctor? What was your pain level at the worst this last week? What is it on average? And, they do what they call the PEG scale, pain, enjoyment, and your activity level. That was all implemented as part of the strategy. That's going into their database to look at our data so they could study us, so they could gather up enough data to create a best practice and then implement it on those of us that are already sick and implement it as a strategy to prevent others from getting sick. I know I'm repeating myself, but this is really, really important. Okay. They state here that there may be a role for the redesign of the electronic medical record or health record to facilitate assessment, including integration of meaningful use criteria to increase its adoption. Meaningful use is, I don't have a really good definition, but if you look it up, it'll give you a better definition than I can. Meaningful use is making sure you're putting in the data so that it can be captured, and the data that is meaningful and important to help you assess and deal with the situation that you have at hand. Okay? Despite what is commonly done in current clinical practice, there appear to be few data to support the long-term use of opioids in chronic pain management. Several workshop speakers stress the need to use treatment options that include a range of progressive approaches that might initially include non-pharmacological options such as physical therapy, behavioral therapy, and or proven complementary and alternative medicine approaches with demonstrated efficacy, followed by pharmacological options, including non-opioid pharmacotherapies. The panel reviewed the different types of pain. We've got peripheral, nociceptive, and all these different categories. They really go into that here. It's a very long document, but it's not too long that you can't read it. It's a big font. It's spaced. It's about 40-something odd pages, but there's some charts in the back. They talk about concerns about the patient-doctor relationship being um, interrupted in such a way that there's that lack of a therapeutic alliance. They were concerned about that because they want us to be comfortable. I assume they want us to be comfortable with our doctors so we can speak freely to capture the data. I'm guessing. They state that they want to go to the use of a more effective chronic disease care model that may have implications for reducing the potential of a new generation of chronic opioid users. And I hate that. I hate being called a chronic opioid user. And I had never heard it before until I saw Gary Mendel saying it on his Choices Matter campaign. But here we are back in 2014. They said it. Chronic opioid users. Because from what I can tell, their idea about us is that we sit at home, we take our opioids, and somehow that's preventing us from doing the best that we can, or that somehow the opioid inhibits our ability to get back to work. That's really what this reads like. It says, one simple approach the panel considered to decrease the conversion of acute users to chronic users was to advise those prescribing opioid medications for the treatment of acute pain to prescribe fewer pills to be taken over a shorter but clinically reasonable time frame. And there is some evidence that higher number of pills initially prescribed is related to the risk of chronicity of use. Here you go with the guidelines. And later on in their recommendations, they state that doctors should be following guidelines. Okay? They say that pain is a multidimensional problem, ranging from discomfort to agony and affecting physical, emotional, and cognitive function, as well as interpersonal relationships and social roles. As with other chronic conditions, chronic pain management requires a more comprehensive biopsychosocial model of care. Okay? And they went on to say that primary care doctors they're kind of stating that they don't have the capacity to fully exercise, guiding us through this multimodal uh, chronic care management because of the time constraints that have been put on them and with learning the electronic medical record. And so they've recognized that our doctors are tapped for time. But if you really think about it, those of us who've been on opioids for a long time, don't you guys remember? It was patient centered. They talked to us, they listened to us, they helped us. We went to physical therapy, we tried other things. That was already in place. It's almost as if they've taken this as an opportunity to say we need multimodal biopsychosocial care and all these things. But if you really think about it, on many levels, that was already occurring. They state in here that, the payment structures are barriers to non opioid alternatives, basically implying here that they want the physical therapy, CBT, medications they name Lyrica here to be offered as a primary thing that we go to before we get to the opioids. So, okay, we understand that, right? They recognize in this report that we were suffering because of the way that the media reported on us all the way back in 2014. And they said that the way that the media was not talking about pain management and how beneficial and how wonderful that can be, but instead focused on the drugs and the overdoses. And like I mentioned before, and actually I heard some other entity bring it up recently, the picture of the people in the van with the needles in their arm, passed out with the kids in the back. They knew that the media was framing this to get everybody whipped up into a state of hysteria, yet they did nothing to stop it. Why is that? Why is that? Because they wanted to leverage the addiction overdose crisis so that they could bolster the support for taking away our medication, because they were not going to be able to actively and effectively study us until we didn't have the medicine. In this report, they recognize that because our opiates are effective and we're satisfied with our treatment, that it would be really difficult to find patients that were going to be willing to abandon that. They said it in this report. We have the proof now, you guys. They said it in this report. Okay? I want you to read it for yourself, but it's there. The only way that they could get the data they needed to test the alternatives to create the strategies was to have a sample size large enough of people that were not currently taking opioids. They acknowledged we could be harmed, and they said, they implied, they wrote, however you want to say it, that they had to weigh that, and that they chose the benefit of the population over the benefit of the individual. They didn't know how they were going to enroll us in these trials. The researchers would need patients to enroll in the trial that were not actively utilizing opioids. This would enable the researchers to test the effectiveness of certain alternative strategies: yoga, cognitive behavioral therapy, acupuncture, physical therapy. After these treatments were tested, if any were found to be beneficial, they would be engineered into best practices and utilized on those in need of care. The researchers hypothesized that patients who use opioids long term, aka chronic opioid users, remain disabled as an outcome of taking opioids long term. They also hypothesized patients who were not offered opioids but rather offered non pharmacological therapeutic treatments would regain function faster and be able to reintegrate themselves back into the workplace despite not having decreased pain. You've seen this over and over recently in the things that are coming out, that the focus is not our pain level, it's our level of function, because that's what they were going for. They wanted to decrease the rate of disability. So, see, you have to understand here that the best practices pain management report that came out of HHS, the reason that was drafted is because there were gaps. Okay. This was created alongside the National Pain Strategy. The National Pain Strategy is a research strategy, so they could define and look at pain in our society and figure out ways to get people back on their feet and more functional. So we have the National Pain Strategy, but they didn't have all the data they needed. So what they did is they had to have meetings, and that's where the Best Practices Pain Management Task Force report comes in from HHS. Those were the gaps. If you read the report, you'll see the gaps. Those are the holes they want to fill, and those are the things that are going to be done to fill those holes so that they can have all of the research. Okay? So when I see that, you know, when I see patients wanting the pain management task force to be implemented, there are some good things there. Okay. We do want to have every single thing we can get our hands on to make ourselves better, right? There's nothing wrong with that. My issue with this is that they knew. They knew why the guidelines, why the medicine was being taken. And when people were suffering and they would go to their lawmakers and say, help me, what's going on? And they were given that confused look and not given anything to go on so they could wrap their heads around it cognitively. They walked away in confusion. And then all of a sudden we have the task force report come in like it's going to save the day. Well, maybe on some level it will. But why didn't you tell us the truth? Why didn't you think that we were capable of understanding the truth? Why did you have to take such a heavy hand? And why is it that when advocates came out and recognized that we were in a study, that they were shot down? Why? Because it's the truth. It's right here in your own words. Why? It doesn't make sense to me. So I'm going to attach this to my scope. It's going to have the email that Lauren and I wrote that puts it in a really condensed, summarized way. Then along with that, there's going to be one of the very first links, and we put it in blue. That's going to lead you to this document from the NIH. Okay? It's called Pathways to Prevention Workshop, the Role of Opioids in the Treatment of Chronic Pain. That is this document that will tell you everything they discussed and did. This is the truth. The gig is up. We know now for sure. We are in a study. That's why they did it. That's how they did it. You know, once we get past this and we can start talking about the truth, that this is civil rights, you guys. It was never really about the opioids per se. This is about our civil rights. And we need to start talking about it in that way. I said it when I did a video a few months ago called You've Been Lied To. And I watched it a few days ago, and I said, you know, they're not listening to us, you guys. They were going to our lawmakers going, oh, but I hurt, and oh, we need help, and no, I'm not abusing our medicine. They knew that. It's here in this report. They know that, okay? They know that. So let's start talking about the truth. The truth is, you want to study us. You want to change the way pain care is practiced. You want to get more people back to work. Tell the truth. And when you tell the truth, that gives us the tools to work toward solutions. Okay? That's my message tonight. Let's work toward solutions. So no more of the CDC. They didn't act independently. Here's the proof. No more about Kolodny. He's just a front man to distract everybody. That's what they wanted. Let's not be distracted. Let's read this document and let's hold these people accountable for telling us what they did and why they were never open with us. And once we do that, then we can start discussing all the profiteering that's going on as a result of this, like with Pacira. We can start talking about that because, see, those are little things that spun off of this. We need to ask for oversight. We need to ask for regulations on these people that are studying us, because right now they're getting billions of dollars. They're going hog wild. They're utilizing good taxpayer money for this, all under the guise of the opioid crisis. It was never about the opioid crisis. It was about you and I and our painful disease. At the end of this document, they have the recommendations. I'm not going to bore you any further. I'd be happy to do some subsequent periscopes if there's anything I can explain. If there's any concerns about my research and about my interpretations, please reach out to me. Let's talk about it, because I always want to be transparent, always want to share where I get these things from. I want to teach you guys how, I'm sure many of you know how, but let's learn together. Let's be together as a community. Yeah, we all don't work in the same advocacy group. We've got little groups here and there. But you know what? We're all working toward a common goal. Okay? Let's start talking about the truth and let's get through this. 2020 is going to be an amazing year. All right, you guys. I'll be back tomorrow. We need to start getting this out to our lawmakers. They need to know that we know, and we're done. We're done talking about the opioid crisis. Let's talk about the solution and how to get patient care for people like you and I solidified so we don't have to live like this anymore. All right, you guys, I'm going to go to bed. I hope you all have a great night. Please read this document. I am here for questions. Please reach out to Lauren and I. Let's help each other. Let's get through this. Let's get to the bottom of this, and let's put a stop to it. I want my civil rights back. Good night.